our UMass Lunch and Learn series of talks for the 2024-25 academic year. So this is a bi-monthly lecture series that's hosted by the University of Michigan Addiction Treatment Services, or UMass, that aims to inform and to enhance clinical practice through the exploration of topics related to the etiology, prevention, and the treatment of substance use and substance use disorders. So before we go on, I want to thank the other members of our Lunch and Learn committee, Dr. Megan Martz and Wendy Yallop, as well as the administrative staff who have been really essential to pulling the series together, Teresa Vogel and Angela Tiberian. And so now it's my pleasure to introduce our speaker for today, Dr. Jonathan Morrow, who's an associate professor at the University of Michigan Department of Psychiatry. Dr. Morrow received his MD from the University of Michigan along with a PhD in neuroscience. His research focuses on delineating the basic neurobiology that underlies motivated behavior and determining how variation in neurobiology can lead to psychopathology and substance use disorders. So he primarily uses animal models to understand neurobiological mechanisms behind disorders like PTSD and substance use disorders. He's also received clinical training both in adult psychiatry and in addiction medicine, and he's a practicing clinician at UMass, as well as supervising a number of our psychiatry residents. So he's particularly interested in the topic that he's going to be talking about today, which is the treatment of substance use disorders along with co-occurring conditions, especially post-traumatic stress disorder or PTSD. So a warm welcome to Dr. Morrow, and go ahead and take it away when you're ready.
Great. Thanks a lot for that introduction and for the invitation to do this. Let me share my screen here so you can see the presentation. Yeah, that should be working. Okay. So as Alex said, I'm a clinician at UMass where I treat substance use disorders. I do spend a lot of my time doing basic research on neurobiology of motivated behaviors, but this is going to be a clinically oriented talk. So if you're looking for that, you'll have to go to a different talk venue. But this will be focused on treatment strategies for folks with post-traumatic stress disorder and a substance use disorder. And the way I'll talk about this, there we go. So the way I've structured this is I'll spend some time at the beginning on a little bit kind of theoretical talks about how PTSD and substance use disorders are related to each other. And then I'll go into some of the specific treatments that have been tested for use in patients with PTSD and substance use disorders. And that'll be medications. A lot of the time will be spent on psychotherapy as really a mainstay for this combination, and then a little bit on peer support as well. And then I'll end with just some takeaways. So I'll give you the main points at the end. All right, so first of all, one of the reasons we talk about this is that PTSD and substance use disorders seem to be related to each other. And the easiest piece of evidence for that is just when you look at prevalence rates of PTSD and substance use disorders. So in the case of PTSD, the prevalence in the United States is somewhere around 10% of people have a diagnosis of PTSD in their lifetime. And substance use disorders is kind of similar level. The prevalence is more like around 15% will have a substance use disorder at some point. Even though actual exposure to drugs, it's about 90% of people will be, over 90% really, will be exposed to addictive substances. And with traumatic experiences, it's about 90% of people will experience something traumatic in their life, but it's only a minority of them actually develop the disorder. But if you look at the two of those together, they occur much more, that comorbidity occurs much more commonly than you would think based on those prevalence figures. If they were unrelated, then people with PTSD, about 15% of them should have a substance use disorder, but that's not what we find. It's usually much higher than that. And this is an example of a study in combat veterans with PTSD. About 75% of them met criteria for alcohol use disorder. And if we look at people who are getting treatment for substance use, this study had 42% of them meeting criteria for PTSD. So there's something that's relating these two disorders to each other. And it's important to point out, this 75% and this 42% in this study, this was diagnosed as part of the research study. Most of these were undiagnosed disorders. So, and they wouldn't have been diagnosed if these people hadn't been screened as part of the research study. So, so a lot of this goes unrecognized, but it's a very common comorbidity. And if you talk to patients about these two disorders, they believe that these are functionally related to each other. And they prefer treatment that's integrated, that takes into account both the PTSD and the substance use. It doesn't make sense to them to talk about one of these without talking about the other. They really relate to each other. And that'll come up as a theme later on. But they are interrelated. So why do we care about that? One of the big reasons is that this comorbidity worsens outcomes, clinical outcomes. Each of these conditions, PTSD and addiction, makes the other one more severe and more resistant to treatment. That's been shown in a number of ways. They have worse clinical outcomes in a variety of measures, whether you're looking at, so there's global assessment of functioning, hospitalizations, for psychiatric outcomes, but also just physical health, interpersonal problems. All of these things are worse with that comorbidity. So that's why it's important to understand and have some treatment strategies for. And clinicians, we tend to see these cases as more challenging. These are the, this is a train wreck, whatever people say when you have a really complicated case coming in. That usually gets applied to people with this particular comorbidity, PTSD and addiction. So I want to spend a little bit of time at least thinking about why PTSD and addiction co-occur so often. And there's a number of explanations for this, which they're not mutually exclusive. So they're probably several or even all of these may be true, but we'll go through just a few of them here. So one possibility is that some people are just inherently vulnerable to both PTSD and addiction. As I said, for both of those disorders, something has to happen for you to get it. You have to be exposed to drugs to have a substance use disorder, and you have to be exposed to trauma to get PTSD. But not everybody gets that if they're exposed to it. The vast majority don't. And there is evidence that it's just some people are vulnerable to addiction, and it's the same people who are also vulnerable to PTSD. There's some shared vulnerability factors there. So that's probably part of the explanation. Whether some of that may be genetic, some of it may be early life experiences and whatever, but they're just inherently vulnerable to both disorders. There's another class of explanations that basically posit that addiction or the substance use disorder comes first and somehow causes the PTSD or raises the risk for PTSD. And one mechanism there is just that drug use increases your exposure to traumatic events. A lot of times this is illegal drug use. It involves illegal activities, which that exposes you to dangerous situations. Also, people who are intoxicated are more vulnerable to having something traumatic happen to them. So that's probably part of it. But also neurobiologically, drug use sensitizes the hypothalamic pituitary adrenal axis, the HPA axis. So it heightens the stress response, and it may increase vulnerability to psychopathology as a result of a lot of traumatic stress. And another class of explanations is basically that PTSD somehow causes addiction. And similarly, neurobiologically, traumatic stress sensitizes the reward circuitry, so that those traumatic experiences will raise the likelihood that someone will develop an addiction once they're exposed to addictive substances. And also, there's PTSD patients may self-medicate with drugs, so that they have PTSD and they're trying to treat their own symptoms with addictive substances. And this one, I think, merits a little more discussion. This so-called self-medication hypothesis. This hypothesis remains the dominant explanatory model for the relationship between PTSD and substance use disorders among the general public and among most clinicians. That's generally how they think this works. But that hypothesis relies very heavily on anecdotal evidence, patient perceptions, things like that. And there's some clinical findings that don't really fit this hypothesis very well. For example, you would think if people were trying to self-medicate their PTSD symptoms, they would choose specific drugs for specific symptoms. So, for example, if they're getting a lot of hyperarousal, you would think they would use some sort of sedative drug to bring that down. But there's not much evidence for that kind of substance use in the case of PTSD. In fact, so one example is there's a very high comorbidity between PTSD and cocaine use disorder. And I mean, there's just no scenario where cocaine makes PTSD symptoms better. It definitely makes it worse. Yet they're drawn to cocaine. That really doesn't fit with a self-medication hypothesis there. There's also not much evidence that treating comorbid PTSD symptoms improves the substance use disorder. So if they were using in order to bring their PTSD symptoms down, you would think that improving the PTSD symptoms would lead to less substance use. But there's really not a lot of evidence for that. Now, I'm not trying to suggest that there's nothing to this self-medication hypothesis. I do think that people get drawn into substances as a result of their PTSD. They do try to self-medicate with drugs, and then that can develop into a substance use disorder. So it may lead them down that path. But once you've developed a substance use disorder, it really doesn't have anything to do with self-medication anymore. You have a separate disorder. It's addictive use at that point. And solving the PTSD problem still leaves you with the addiction problem. So I think it leads them down that pathway, but it's not really what sustains the use once a use disorder has developed. Okay, so let's talk a little bit about treatment strategies here. So there's a few different overall treatment models for so-called dual diagnosis patients. This is kind of an outdated term, but it's referring to people with both a substance use disorder and some other kind of mental health disorder, PTSD, or really any kind of other mental health disorder. So one model is sequential treatment. This is the traditional approach to dual diagnosis situation. And the principle here is that you want to stabilize the more acute condition first before you tackle the other disorder. The idea being that it really doesn't, you're not going to get anywhere, say with the PTSD. You're not going to get anywhere treating the PTSD unless you solve this addictive substance use first. Um, the problem with this approach, though, is that it doesn't really address the interrelationship of the two disorders. I mean, it's not wrong in the sense that, you know, if you don't treat the addiction, it's going to be difficult, if not impossible, to treat the PTSD. Um, but that logic works both ways. You can't really address the substance use unless you also address the PTSD, because they're affecting each other. So how do we get out of this kind of catch-22 situation? Which one do we do first? Um, the preferred method now is integrated treatment, um, where you have to address both disorders at the same time in order to actually make progress for most of these patients. Um, and so ideally, this would be integrated, meaning the same treatment team is addressing both of these disorders, both the PTSD and the substance use disorder. Um, the problem with this approach, though, is really practical. Um, you have to have people with a lot of training that is sufficient to address both the PTSD and the substance use disorders. And there's not a lot of places that have that kind of expertise on their staff, and especially with substance use treatment programs. Our UMATS is a bit of an exception in this regard, but most of in general, the staff there do not have a lot of advanced degrees. It depends a lot on peer support, peer counseling, um, and so they really don't have the expertise to develop evidence-based treatments for PTSD along with whatever substance use treatment they're providing. So it's just not realistic for a patient to get both in the same place. So the next best thing to this is parallel treatment, where they're getting treatment for PTSD in one place and they're getting treatment for the substance use disorder in another place. But the challenge here is coordinating care. You have to make close communication is essential for this, mainly because you can have contradictory approaches, contradictory treatment philosophies at the two places, and that can be really confusing to patients, and it can disrupt their care. So making sure that everyone is on the same page is really essential to this type of approach, not just for PTSD, but really any kind of mental health disorder that you're addressing along with the substance use. Okay, so now if we get into specific treatments, I'll start with pharmacological treatments for this comorbidity, PTSD and substance use disorder. And I'm starting with this because I can summarize it very quickly. There are no pharmacological treatments that have been demonstrated to improve both PTSD and substance use disorders. There are pharmacological treatments that are effective for PTSD, and there are medications that are effective for a substance use disorder, at least certain substance use disorders. You can use those in this population. They don't interfere with each other. They don't interfere with psychotherapy, which is not a trivial point. You know, there are some medications that will interfere with psychotherapy, but the ones that we use for substance use disorder do not. And they are effective in this population with the caveat that all treatments are less effective in this population than they would be in someone who doesn't have a comorbidity. They're difficult to treat in general, but they do respond to the same types of medications that people without this comorbidity would. So you can use the same pharmacological approach. You don't really have to modify it that much for someone who has this comorbidity. A little more nuanced and interesting is the psychotherapy approaches for this. I'll spend a little more time on that. What I'm going to do is just kind of I'll basically list the psychotherapy approaches that have been shown to benefit people with both PTSD and substance use disorders. And then we'll go through some of the conclusions we can draw from that broader literature. Um, so I'll start off with single disorder treatments that have been shown to work in this specific population. So by single disorder treatment, I mean something that was designed to treat substance use disorder by itself without the PTSD. Also works for people with both substance and PTSD. So one of these is relapse prevention. This is probably the most widely used approach for substance use disorders. It's a CBT, a cognitive behavioral therapy approach. I think it's the one we rely on the most in UMass, for example. And that's been shown to work with people with PTSD as well. There's Brenda, which is probably more, I don't really need, it's not worth going into the full explanation of what Brenda is, but it's an individualized method for addiction treatment along for people who are getting pharmacotherapy for substance use. It's been shown to be effective for people with PTSD as well. And then there's a couple others. So there's individual addiction counseling. That's actually the name of the intervention, individual addiction counseling, which combines drug counseling with 12-step facilitation, and alcohol support, which is a combination of CBT and behavioral interventions for alcohol use disorder. All that's been shown to be beneficial in this specific population. And then if we turn to treatments for PTSD, prolonged exposure therapy, which is kind of the gold standard treatment for PTSD, that's been shown to be effective for people with comorbid substance use disorder as well. EMDR, which is kind of a variant really on an exposure-based treatment, also is effective in this population. And then there's at least one type of reprocessing therapy, the structured writing therapy for PTSD, which is not exposure-based, but that also has shown efficacy in this population of people with a comorbid substance use disorder. So any of these can be useful, and there's no reason you can't combine these. So if you have someone, if you want to recommend relapse prevention for their substance use disorder and concurrently prolonged exposure for their PTSD, if the patient has the time, the resources to do that, yeah, that's a perfectly fine approach for this comorbidity. But there's also some integrated treatments, integrated psychotherapy treatments that have been developed and have also shown efficacy in this particular population. So I'll go through some of those here. So the first one is called seeking safety. That's I think the oldest of these techniques. It's a cognitive behavioral therapy type approach that has really been designed for this particular comorbidity, PTSD with substance use disorder. That was developed, I think, like in the 1980s, and that's definitely shown efficacy in this population. There's a newer one called COPE, what is it, concurrent treatment of PTSD and substance use disorders using prolonged exposure. So that is a combination of prolonged exposure and relapse prevention. And that has also shown to have efficacy in this particular population. So both an exposure-based and a non-exposure-based type of psychotherapy, integrated psychotherapy, have shown efficacy. There's something called integrated cognitive behavioral therapy. I'll just go through. There's one called integrated treatment. That combines a lot of different things: exposure, reprocessing therapy for PTSD, and a couple of like the cognitive behavioral therapy and behavioral interventions for substance use disorder. So but it's manualized. So, but anyway, that intervention has been shown to work. And then there's a modified prolonged exposure, which basically adapts prolonged exposure for substance use by shortening the sessions, adding some education for substance use and some breathing techniques. So that's also shown efficacy in this particular population. So all of these approaches have been shown to work. And I'll give you some takeaways from that overall literature. But before I get to the takeaways, I want to talk a little bit about the limitations of the evidence that exists right now for these interventions. One of the biggest limitations in this particular field is that clinical studies tend to exclude substance use disorder patients from their study populations. And kind of amazingly, even studies that were specifically designed to look at the PTSD substance use comorbidity sometimes exclude substance use disorder patients from the study. For example, like we don't take people who are using cannabis or nobody who uses heroin or something. So it's not clear a lot of times how much this will translate to the actual patient who's in front of you, because they may not fit those criteria, so it doesn't work with them or not. Some of these interventions have only been studied in intensive substance use treatment settings, so like residential treatment for substance use. An example of that would be that modified prolonged exposure that I talked about. That's really only been, I think it's really only been tested in a residential program. So for somebody who's not in an intensive substance use treatment, it's not clear exactly how that would translate. Maybe it would, but hasn't been studied really. And then a lot of these studies will exclude what are called complex patients with a lot of, basically people with a lot of symptom burden, as evidenced by suicidality, psychiatric hospitalization, borderline personality, homelessness, incarceration. Those folks probably have not been included in these studies. So it's really an open question how much these interventions would benefit them as opposed to people with the somewhat less clinical burden that have actually been studied. But with those caveats, I can give you some broad takeaways from the evidence here. So one thing, actually, this was a paper that I just found while I was putting these slides together. I thought it was interesting. One is that most patients with this comorbidity, with PTSD and substance use disorder, seek treatment for those disorders. That was a bit surprising to me, but most of them actually will seek treatment for that. And about 84% of those folks actually receive treatment for their mental health disorder, which I was also surprised. I mean, that's really pretty good that so many of them actually received help for it. But only about 36% receive treatment for their substance use disorder. So that tells me that we need to do a better job of getting these folks into substance use treatment. And some of that may be just screening and recognizing that they have PTSD, but then also once you see that they have this disorder, let's get them into substance use treatment. They clearly need it. There's been some argument that maybe they don't need. They definitely need it, so they should get it. Another takeaway, just broadly from a lot of these studies, is that PTSD will often improve without any effect on the substance use outcomes. This has been the result in a lot of these studies. And what I conclude from this is that, well, one, I've already mentioned that the substance use isn't really driven by the PTSD at that point, once they have an addiction that's developed. But also that PTSD may be a little, it's easier to make some improvements in the PTSD than it is with the substance use. That's a harder nut to crack, it seems, for these folks. Also, some of the substance use interventions, like relapse prevention, that doesn't address PTSD, also will improve PTSD symptoms. So kind of the reverse point of what I made earlier is not true. So it does seem that the PTSD symptoms are exacerbated by the substance use, and if you can make some movement in the substance use, then that should improve their PTSD. But some of those interventions that's actually turns out to be somewhat of a treatment for their PTSD as well. But the best outcomes come from integrated interventions. The exposure-based ones tend to do better than other forms of interventions, which fits with the broader PTSD literature. But that tends to be the best outcomes, particularly if they're manualized. If there's a manual to go along with it, it seems to work better. That honestly, that might be an artifact of the way scientific research is done and how you evaluate that. But definitely the ones that were manualized had better outcomes than the ones that weren't. Um, so this being the case, it's fairly clear from the literature that exposure-based interventions are helpful, and they're really the most helpful approach for PTSD in these circumstances. But a lot of clinicians are reticent to do that, to refer people for exposure-based intervention. So I want to address that because the concern here is what's called the Pandora's box hypothesis. And this is a belief among clinicians, and that's really what it is. It's a belief among clinicians that exposure therapy is going to arouse negative emotions and it's going to lead to increased substance use. Because the way you do exposure, if you're not familiar, the way you do exposure therapy is you for PTSD is you actually bring up the trauma in a controlled situation with this patient, and they need to learn to deal with the responses that come from that trauma without escaping or running away from it. So that they develop skills for that. But that's difficult, as you. I mean, they're avoiding these memory for a reason. So so the worry is that you bring up all these negative emotions, that's going to cause cravings and relapse in these folks. But this has been studied, and studies have shown no risk, really no risk, not low risk, but no risk of PTSD symptom exacerbation from exposure therapy, at least as compared to other types of psychotherapy. And that's true even if your comparison psychotherapy is substance use focused. You're not talking about the trauma at all. In that you'll get symptom exacerbation at the same rates as if you were doing exposure therapy. So it's really there's not evidence to support that fear in clinicians. And specifically, if you're looking at substance use exacerbation, there have been multiple studies. I've cited some of them here, but there's multiple studies that have not shown an increase in substance use. And in fact, what they show very consistently is a decrease in substance use among people who are in exposure therapy for PTSD. So I would encourage you to refer people for exposure therapy. Don't be afraid to do that. To refer them for exposure therapy for PTSD. I've certainly had patients who've had exacerbations, and you know they may be kind of on a knife edge there, and it's scary to destabilize them more. But the evidence just isn't there that you're actually destabilizing. The evidence is that that's going to make them more stable. So that's really what you should do. And you know, some patients they don't feel ready for that. They're not gonna, if they're really not ready for that, they're not gonna do it anyway. They're not gonna go through with the exposure therapy. But I would say to go ahead and refer them for it, because I mean, the evidence shows this is the best treatment for them. It's their best chance of getting better. Okay, so that's that little piece. I'll spend a minute here on peer support as well, because that's a big part, at least of substance use treatment a lot of times. The evidence here, I'll just say, the evidence here isn't the same level as with the psychotherapy interventions or the medication interventions for that matter. I think that's largely because peer support is hard to study in a really controlled. I mean, it's not a standardized intervention. It's really hard to do a good quality study of peer support. But the available evidence seems to show that self-help groups improve outcomes for the dual diagnosis patients. I can't say for PTSD in particular, but in general, with people with comorbid mental health disorders and substance use, yes, these self-help groups improve outcomes for them, as well as for people without the comorbidity. There is some concern in AA, the Alcoholics Anonymous, which is the biggest of these groups, that medication, psychiatric treatment, but particularly medications, are discouraged within Alcoholics Anonymous. And historically, that's definitely been true. That's been changing over time. And I can say there's official AA literature that supports psychiatric medication when it's appropriately prescribed. I mean, the hostility within that community, it's there for a reason. It's because there's a history of psychiatrists really not prescribing medications appropriately. But the culture has been changing, and so even things like buprenorphine, methadone, that's more and more accepted within the AA community. So you can give patients some ammunition to say, no, this is supported by the AA model. They don't necessarily have to tell anybody in AA that they're on these medications if they feel like they're going to get harassed about it. But it's perfectly compatible with that, with peer support in that way. There's also some dual diagnosis groups. I've listed some of them here: Double Trouble in Recovery, Dual Recovery Anonymous, Dual Disorders Anonymous. Honestly, I can't say that I've referred a lot of people to these groups, mainly because they're small. I mean, there's not as many of those groups, so it's harder to find a group that's going to be convenient for the patient and whatnot. I usually will just refer them to AA, but these groups do exist, and so they could be useful to some patients if they're really struggling, particularly with that comorbidity. All right, so yeah, we'll leave some time for questions here. So I'll give you I'll summarize the key takeaways from what I've said here. So number one, I didn't really spend a lot of time on this, but I do want to emphasize it. We need to screen for these disorders. You can't treat what you don't diagnose, but these are very common disorders, and it's important to try to recognize that even if it's not what the person came in for, they may also have this other disorder that's going to make it very difficult to treat whatever they came in for if you don't address it. And it's not just the initial screening either. Both of these are pretty sensitive diagnoses, and somebody, the first time you meet them, they may not respond positively when you ask whether they have a substance use problem. That may come out later. And similarly, they may not want to tell you about the most traumatic experience that they've ever had in their life the first time they meet you. So keep that in your mind and come back to it, and stay alert for these other diagnoses that the person might have, especially if you're having trouble with the treatment and trying to figure out why this isn't working very well for this person. The optimal approach is integrated treatment. When you can get it, it can be challenging to get, but that is the optimal approach. If you do parallel treatment, close communication is key between the providers. And I would say most importantly, don't withhold treatment for one disorder because the person has another disorder. You want to provide treatment for both disorders simultaneously. That's how people get better. They're interrelated disorders, and just that approach of just focusing on one at a time is unlikely to be successful for the patient. It's also unlikely to make any sense to the patient. So that's what I would encourage you to do. All right, so that's all my slides, and I'm happy to take any questions if people have them.
And thanks for the great talk, Dr. Morrow. I guess one of the questions that I had is when you were talking about some of the limitations of the evidence, basically, and talked about how oftentimes a lot of these clinical trials may focus specifically on one substance and exclude folks with polysubstance use. I mean, is there a specific substance or set of substances where most of this work has been done, or does it generalize to most of these most of the disorders it's been studied in?
I mean, a lot of it was alcohol. There's been some of these studies that have just exclusively focused on alcohol. Um, but it's, the others have been kind of a hodgepodge in what they'll exclude. Some of them excluded benzodiazepines, some of them excluded, and I mean, there's reasons for doing that, but just if you look at the individual studies, a lot of them have excluded one substance or another. So it does raise the possibility that, maybe it doesn't apply to all of them. It's rare that you'll get one that takes all the type of psychopathology that you're likely to see. So yeah.
Makes sense. And that's kind of I guess, a general limitation of clinical trials, right? For most things,
Yeah.
this homogeneity.
Yeah. Yeah, although it's, just generally for substance use treatment, I think that's particularly problematic because that one is like always excluded. I mean, unless it's specifically designed to look at this comorbidity, almost all of them will exclude substance use from any trial that's been done. So it's hard to say, are these standard approaches going to work for my patient if they have a substance use disorder? Because nobody's actually studied that. So yeah.
All right, thank you. Do anyone else have questions? We have some time for discussion if folks do.
Dr. Morrow, I have a question.
Yeah.
Do we know of any good places to refer for trauma treatment, or do we do any of that here at Michigan Medicine?
So, I mean, we have patients who do trauma treatment, so certainly through the anxiety disorders clinic. Maybe, I don't know, if some of them might be on the call, but we do have patients who do that. And I mean, we don't have many who do both within UMass, although we just hired, what's her name? You know what I'm talking about. We do have one, we do have one person here. But yeah, just offhand, I'd have to get back to you on that. I think we have a resource list of places that do that. It's not an extensive list, but there are some, yeah. Oh,
Ella just replied, thanks, Ella.
oh yeah, the trauma groups. Yeah, yeah.
Yeah, I'll chime in that the adult anxiety clinic, we do have a trauma treatment program with a series of groups and then also several individual providers that are trained in evidence-based trauma therapy. I personally have worked with some patients who have trauma-related disorders, including PTSD, with comorbid substance use disorder, and they were also being seen in UMATs. So I've had some of that experience of doing like the parallel treatments. I think it's much harder to find, which I know you've already mentioned, John, a provider who is an expert in both and can address both in the same treatment protocol.
Yeah. Yeah, and I've done that a lot with referring outside of UMass for the trauma treatment, like this individualized trauma treatment. I'll refer outside for that. And most of them, they're also getting treatment within UMass because they don't have the substance use piece. But there are a few who have both. Yeah. And there's some of the treatment facilities for folks with a lot of acuity, like there's Sanford House and Pine Red. Like they'll have staff who can do both of those types of treatments. Yeah. But yeah, somebody, I think it was Michelle, said care management can help with these types. I definitely lean on them quite a bit for these types of referrals too. Oh, and I guess I didn't mention it during the talk, but there are some emerging trials on the medication side that, we may have some treatments that end up treating both PTSD and addiction. It's just that I don't think the evidence is there yet to really recommend that. But there's things like ketamine, psilocybin, cannabinoids may play some role, but like I said, the evidence base isn't there yet to recommend that for folks.
I have a quick question. I was wondering, the suggestions that you outlined in today's talk, do they apply to all age groups across the board, like including adolescents as well, or are there different recommendations for that age group?
It's a good question. These studies have been done in adult. I can't think of any that were adolescent. I haven't seen anything that would say that adolescents are different. I'll say that. So I would assume it's the same, but I don't know that that's been specifically studied in that particular population. It may have, but I don't recall any offhand that were adolescent focused.
Great, thank you.
Yeah, I mean, a lot of those conclusions are they're pretty broad types of conclusions that have held true across different psychiatric disorders. So not just PTSD, but other disorders as well, in terms of the broad recommendations there. So
That makes sense. Thank you.
All right, so we're seeing a lot of nice recommendations in the chat for local resources as well, so I want to highlight that. And if no one else has any questions, we can end. I want to remind folks to claim their attendance with the links in the chat. There's separate links for medical providers and social workers. Dr. Morrow, that was a great talk. Really, really relevant and exciting, exciting work. I guess, do you have anything else you'd like to leave us with?
no, just thanks for everyone's interest and time with this presentation. Yeah.
Excellent. All right, well, thank you. Thank everyone for coming. I hope you have a great rest of your day. We'll send out additional emails for future Lunch and Learn lectures soon, and I hope to see you all there.
All right, thanks.